dysfunctional uterine bleeding. But now it's known as AUB. A means abnormal. Abnormal uterine bleeding, AUB. And then we'll go into endometrial hyperplasia, and then tumors of the endometrial cancer, and then tumors of the myometrium. So myometrium ada dua tumors. One is benign, one is malignant. So benign is small muscle. Uterus is made up of small muscle, so it's leiomyoma. And then we'll go to the malignant one is leiomyosarcoma. Okay, and then kena bezakan what is endometrial hyperplasia versus endometrial carcinoma. So hyperplasia is a precursor for malignancy. It can turn to become endometrial adenocarcinoma. And then the rare tumors is MMT, triple MT, mixed Müllerian tumor. It's a type of kind of tumor. Alright, next. Okay. Stage 2 is the cervical pathology. There is squamous metaplasia. What is metaplasia? Change from one cell type to another cell type. So squamous epithelium tu dia punya lining is what? The ectocervix is lined by stratified squamous epithelium. But as it goes to the canal, to the endocervix, the endocervix is lined by mucin secreting columnar epithelium. So kat mana dia transform from the squamous epithelium, they transform into columnar epithelium. That area yang dia transform tu is called transformation zone. So dekat area tu yang selalu ada dysplasia, boleh jadi dysplasia, and then cervical cancer. So cervical cancer is very, very, very important. Very quite common. Common tumor in ladies. Alright. Okay, so that's called the TZ zone. So in the cervix, you can have acute cervicitis, chronic cervicitis. So yeah, the fourth slide is just to show you the change of columnar into squamous. Kenapa dia bertukar? Why does it change from one cell type to another cell type? For contraction, to increase resistance. Kalau ada peripheral injury, inflammation, so it tries to give more protection. It changes because stratified is more stronger than the columnar epithelium. Okay. Next is the inflammation of the cervix, acute cervicitis. Acute cervicitis selalunya lepas postpartum, lepas bersalin, you can have acute cervicitis. Postpartum, we call it postpartum. The infections can be gonococcal infection, syphilis, herpes infection. In syphilis, we call it chancre. Chancre is syphilitic infection. Ataupun herpes simplex infection, that's virus infection. It can also infect the cervix. So that's acute. So you'll see neutrophils in the cervical stroma. Then when it's more than 2 weeks, it becomes chronic. Kalau chronic cervicitis, this is quite common, very common. And you see, selalu pun sama dekat squamo-columnar junction juga. And in chronic inflammation, the inflammatory cells are chronic cells. Apa dia chronic inflammatory cells? Lymphocytes, plasma cells, and macrophages. The major one is macrophages. It's a chronic inflammatory cell. So you see a lot of these inflammatory cells in the cervix. And you can see redness, edema, fibrosis, and also because of the chronic injury, it can also become metaplastic, change of one cell type to another cell type, the cervical columnar to squamous. And chronic cervicitis is important as it may lead to endometritis, salpingitis, and also PID, pelvic inflammatory disease. Okay, and chronic cervicitis is this chronic injury. So that can also lead to dysplasia. And then dysplasia can also is a precursor for cervical carcinoma or cancer. Okay? And how do you diagnose cervicitis is by clinical history, culture studies, you do pap smear, you can see all the inflammatory cells. And culture studies will reveal the organism, what organism is. And then severe reproductive changes in inflammatory lesions can also mimic precancerous. They might look bizarre looking, but it's more reactive changes because of inflammation. Okay, next slide is the cervical polyp. So dekat cervix boleh berlaku cervical polyp. There's like a growth coming out, protruding out in the ectocervix there. It's about 2 to 5% in adult females, and may be due to chronic inflammation juga. And patient, because of the twisting, and it can bleed. Patient may come to you with PV spotting, bleeding. Bila you check they do a colposcopy, masuk scope dekat the cervix, you see something protruding out, and that is cervical polyp. So the photo down there, that's how it looks like. It looks like it's lined, the polypoidal tissue lined by columnar epithelium. This is secreting columnar epithelium. And there can be inflammation, there can be squamous centroplasia. And what do we do with this polyp is you chop off the neck, the stalk, we call it. There's excision of the polyp, and it is treated. Surgical excision. Okay, next, another pathology of the cervix is Nebotian cyst. Nampak kat gambar tu kan, dia macam shiny, bulat-bulat, kembung-kembung tu. When you cut the cervix, you see that cyst yang bulat-bulat dekat dalam stroma tu. That cyst is filled up with mucin secretion of mucus. Okay, that's what we call Nebotian cyst, and that is because of blockage of the endocervical glands, and also can be due to inflammation. So yang gambar bawah tu, yang bulat-bulat tu, those are the cysts. We call it Nebotian cyst filled with mucus. Okay, next, an important one. This is cervical intraepithelial neoplasia or squamous intraepithelial neoplasia, SIL. Okay, so dulu kita panggil CIN1, CIN2, CIN3. CIN1, when these plastic cells are at the lowest 1/3 of the epithelium, of the ectocervix. Ectocervix kan squamous kan? So kalau lower 1/3 to this plastic, we call it CIN1. Kalau 2/3 of the epithelium is this plastic, we call it CIN2. Kalau full thickness, of the whole thickness of the squamous epithelium to this plastic, we call it CIN3. So 1, 2, 3. Tapi itu dulu. Sekarang we call it low grade dengan high grade. CIN1 we call it low C, low grade squamous intraepithelial neoplasia. CIN2 and 3 we call it high C, high grade squamous intraepithelial neoplasia. So macam nak bezakan mana macam mana rupa CIN1, CIN2, CIN3? We look at the nuclear features, the nucleus of the squamous cells. Kalau CIN1 dia baru besar sikit, larger a bit than the normal squamous epithelium. Okay, we go to the first page dulu. So CIN or SIL ni is a type of dysplasia. Dysplasia means abnormal maturation of cells characterized by enlargement of the nucleus, increased hyperchromatism, then there can be mitotic figures as well. Tapi dia belum cancer, dia belum carcinoma. But it can lead to carcinoma if full thickness dysplasia, we call it carcinoma in situ. In situ means dia belum invade the stroma lah. Dia belum keluar daripada basement membrane menuju ke stroma and invade the stroma. Kalau dia dah invade, we call it cancer. Carcinoma squamous cell carcinoma. Okay, alright. And CIN or SIL can be reversed back to normal. The dysplasia tu, dia boleh go back to normal if you remove all the stimulus or injury. Tapi if you biar lama-lama, it can also lead to CIN1 boleh pergi CIN2, CIN2 boleh pergi CIN3, CIN3 boleh pergi cancer. Okay, so it can progress over time. Okay, but it can also regress. Daripada 3 dia jadi 2, dia jadi 1. No, biasanya high grade dia tak regress. Yang regress biasa CIN1 or 2. The 1 lah biasanya. It's low grade. Low grade type can spontaneously regress. Alright. So this dysplasia is caused by what? What's the precursor? Apa yang memprovoke dia jadi dysplastic? HPV virus, the human papilloma virus. Okay, and about 1/3 or 2/3 of CIN1 and 2 respectively persist or progress to higher grade. So 1/3 all lesions begin as condyloma, mata, or CIN1. Tiba-tiba dia jadi CIN2, CIN3. And progression to invasive cancer may develop in a few months to over 20 years. Lama. Tidur CIN1 lama-lama, about 20 years jadi CIN3. The progression takes some time. But it can also be very fast, especially if there's high-grade HPV virus. Few months dah jadi CIN3 dah. Alright? Okay, the next photo tu, the CIN classification tu, that's to show you the leftmost is the normal squamous epithelium, and then tengok dia nucleus kecil-kecil, pinpoint size yang normal tu. And then CIN1 tengok yang bawah 1/3 of the lower part of the squamous epithelium, you can start seeing the nucleus becomes more hyperchromatic and a bit larger than the left yang normal tadi. CIN2, 2/3 of the epithelium dah dysplastic, very large nucleus, hyperchromatic, pleomorphic. CIN3, there's full thickness dysplasia, bawah sampai atas, the whole epithelium tu dah hyperchromatic, disorganized, there's loss of polarity, there's nuclear polymorphism, nuclear hyperchromatism, so that is high seal. CIN2 and 3 are high seal. Okay, next slide. So, kalau CIN1 is also known as talk about condyloma acuminata ni is an exophytic growth, and it's caused by HPV. Okay, and it is detected clinically by white patches after application of acetic acid to cervix. How do ONG people or ONG doctors recognize CIN or SIL? Dia sapu the cervix tu, dia masuk scope, okay, you can see that macam paruh burung kan, masuk dalam the cervix, and then they open up, then you can see the cervix. Then they will apply this acetic acid. Kalau dia nampak putih tu, dia tahu, okay, ni ada CIN. Okay, and then they will pinch a bit, they do a biopsy, and then they send to us. So we will diagnose under the microscope in this CIN1, 2 or 3, low grade or high grade seal. And they can also see this mosaicism, macam mosaic, mosaicism or punctuation, macam ada dot because of the blood vessels. The photo on the left, there's coarse punctuation before and after application of acetic acid. You see this mosaic pattern. Okay, next slide. Bila ada HPV infection, you can recognize this under the slides. In the microscopic slides, you see HPV infected cells. And these cells, rupa dia macam belah kanan tu, yang tu dia Rosa Ackerman tu kan. You see the squamous cells ada dark wrinkle nucleus surrounded by perinuclear halo. Nampak tak macam clear keliling dia tu? That is koilocytes. Koilocytes are HPV infected cells. So kalau nampak ni dekat mikroskop, bawah mikroskop, oh ni ada HPV ni. Because the squamous cells are infected with HPV, and we call it koilocytes. And you can see the cells have dark nucleus, high NC ratio, the hyperchromasia lah, dark nucleus, and there's loss of polarity. Tak cantik the layering tu, dia dah berterabur sikit. And you can sometimes see mitotic figures or abnormal mitotic figures. Okay, that is CIN or SIL. Okay, next slide. Yang ada gambar cervix tu, ada merah-merah tu kan? That's the gross appearance of CIN3. Yang ni dia dah start to ulcerate lah, macam nak ada ulcer kan? Then the redness and a bit of ulceration. So this is what you see grossly. Okay, then we go to HPV, human papillomavirus. Ni favorite MCQ question. Tanya sikit. You are normally asked what are low grade HPV virus, what are high grade HPV virus. Kau kena ingat. Yang what's important about HPV is it is important factor in cervical oncogenesis. Maknanya dia yang menyebabkan, yang trigger or provoke the cancer formation by infecting the cells. And then when they infect the cells will become dysplastic. And HPV is detected in about 85% of cervical cancer. 90% of cervical condyloma tadi, and that polyp tadi, and precancerous lesions. And there are two types of HPVs: low risk HPV, high risk HPV. High risk kena ingat 16, 18, ingat sikit pun tak apa. 16, 18, 31, 33. Jadi 2, 24 macam tu. 16, 18, 31, 33. Kalau boleh ingat banyak panjang lagi tu baguslah. 39, 45, 51, 52, 56, 58, banyak 59, 68. Ada budak boleh remember 5,000 numbers kan? Ni sikit je ni. 16, 18, 31, 33 lagi. 5, 39, 45, 51, 52, 56, 58, 59, 68. Okay, low risk. Low risk dia ujung. Satu rendah, satu tinggi. 6 and 11, 42, 44. Ingat yang bawah je lah. Ingat 16, 6, 11, yang lain tu high risk lah. Ingat lah juga yang 4 depan high risk tu. 16, 18, 31, 33 at least. Okay. You might be asked in the OSPI boleh, MCQ boleh, SAQ boleh, because they are very important. The low risk and high risk HPV. Okay, 16, 18, 31, 33, 6, 11, 42, 44. Alright, boleh kat depan kat tempat belajar tu. Okay, so HPV is associated in cervical cancer is 85% of cervical cancer cases. So, apa jadi yang 15% lagi? They are not associated with HPV. So maknanya you tak dapat HPV infection pun you boleh dapat cervical cancer because you have other risk factors. Okay. So yang 15% ni kenapa? Because they have poor immune status, poor nutrition and many other factors lah. Ada juga whole gene mutations as well. Okay, the next slide yang ada arrow tu, the flow chart tu. So who gets HPV infection are those who are sexually active. Ngantuk ke? Nak marah? Okay, sexually active, then they are exposed to HPV. HPV duduk dekat dia punya cervix tu, grow kat situ, and then they will change the cervical transformation zone. Kalau dia boleh jadi SIL, and then cervical cancer, which is squamous cell carcinoma. Tapi HPV can also infect the endocervical canal tu, and then that will become adenocarcinoma. Kalau dia infect the ectocervix tu jadi squamous kan, squamous cell carcinoma. Kalau dekat endocervix dia jadi adenocarcinoma. Dua-dua can be associated with high risk HPV. Okay, that's what the diagram wants to show lah. Okay, the next diagram, the HPV pathophysiology. Okay, so ni I nak beritahu macam mana HPV infection 1,000 times more common than low seal. Infection tu daripada normal, bila dia infect, the cells can show low seal pattern. Low grade squamous intraepithelial lesion. Cells dah become besar sikit sebab dia dah reactive because of the infection. And then they can progress to high seal, lagi besar dari nucleus, and then bila dah invade the basement membrane dia jadi squamous cell carcinoma. Okay, ada dua a few oncoproteins which is involved in the pathogenesis. So high risk HPV ni dia acts via two proteins, E6 dengan E7. Tengok yang kat bawah tu, the notes on the right kat bottom tu. High risk HPV acts via E6 and E7 oncogenes. These are the oncoproteins or the oncogenes. Okay, apa dia buat? E6 akan bind kepada P53, so there will be proteolytic degradation of cells, and then dia akan inactivate P53 mediated DNA cause DNA damage of the squamous cells, and it also damage the apoptotic pathway. Okay, then E7 akan bind dekat RB gene. Okay, E6 bind dekat P53 gene, E7 akan bind dekat retinoblastoma gene. Okay, and then it displaces the transcription factors normally bound by RB. Dekat RB tu ada transcription factors, tapi bila E7 dah bind, dah tolak dah transcriptors ke tempat lain, and dia akan inactivate the RB mediated cell cycle regulation pathway. Okay, and RB inactivation ni akan lead to overexpression of P16. P16 ni yang ada dekat virus tu, is a tumor suppressor gene involved in cell cycle regulation by inhibiting cyclin-dependent kinases. So bila kita buat P16 stain, kita nampak this P16 on the squamous cells. Okay, and this is a marker for high risk HPV infection. Dia nampak P16, kita tahu lah dia ni ada HPV. Okay, so two genes involved, E6 and E7 dengan the P53 dengan RB genes. Empat tu kena ingat. Okay, alright. Okay, now lepas dah tahu what is famous SEAL or CIN, we go to cervical cancer. It's the second most commonest cancer in women. Apa dia commonest cancer in women? Breast cancer, and then go down is the cervix. So peak incidence 40 to 54 years old, now getting younger because awal-awal lagi dia dah sexually active. I've seen 25 with cervical cancer, 27 with cervical cancer, yang ada multiple sexual partners. We go into the risk factors. Okay, so it arises where? At the T zone, the transformation zone or the squamo-columnar junction. And the commonest type is squamous, squamous cell carcinoma. Bukan adeno, squamous. So macam mana, how do they present? It can be asymptomatic, benda kat dalam kan? Tapi if they do a regular pap smears, screening pap smears for cervical cancer, we can detect these abnormal cells in the pap smears. Or dia ada vaginal discharge, dia ada foul smelling discharge, but this time normally the tumor dekat cervix tu dia dah ulcerate lah. That's why dia busuk Or cervical cancer, sometimes if it's high, the end stage, stage 4, stage 3, 4, patient dekat dalam bilik doktor tu, you kat luar dah bau dah. Is foul smelling, vaginal discharge. Because of the ulceration. You can present with vaginal bleeding or discharge, pain, urinary symptoms. You can have urethral obstruction, anuria, tak boleh nak kencing, uremia, hematuria, frequency, vesico-vaginal fistula. Meaning from the cervix, they can infiltrate the bladder. The bladder pun forms a fistula with the vagina. Ada connection. And then GIT symptoms, if it's too late, dia dah ada recto-vaginal fistula, they can have tenesmus. Or dia rasa macam sakit, dia nak buang air, tenesmus. And lymph edema in the lower extremities in advanced tumor, dia bengkak-bengkak kaki dah because of the obstruction. Tak boleh, the lymphatic drainage cannot flow. Okay, so there are three gross patterns of cervical cancer. It can be fungating, ulcerating, and also infiltrating. But the commonest is the fungating. Fungating dia macam fungus, dia macam cauliflower macam tu. Dia exophytic macam ni. This is fungating. Nampak bulat tu? And the next photo. And on the right tu is that's the cervix, and you see that whitish or yellowish tumor mass there, or creamish tumor mass with the central area of necrosis and also hemorrhage. So I've given this photo before in OSPI. Okay, and you have to describe how the tumor looks like. Okay, ada ruler kat situ, kena measure. There is a tumor mass measuring berapa sentimeter kali berapa sentimeter, yellowish or creamy in color, and with central area of hemorrhage or necrosis. Okay, so that is how you describe on OSPI. Boleh? Boleh kat bawah tu. Add your notes. So what are the risk factors for cervical cancer? Ni pun commonly asked in exams. List 4 risk factors for cervical cancer. So list lah. Ada yang macam-macam, apa mula jawab. Your seniors before lah. I hope you all tak macam tu. Okay? Entah apa-apa. Diabetes, hypertension pun keluar. So cervical cancer, dia sexually active group kan. So benda-benda yang related dengan sexual activity lah. Early age at first intercourse or early first childbirth, okay? Multiple sexual partners, or your partner having multiple sexual partners. You partner seorang je. Janganlah partner itu jahat. Okay? Hai, kenapa ni? Increased parity. Increased parity means dia banyak anak, multiparity, multiparous ladies, because dia ada frequent injury to the cervix kan. Cervix banyak kali kembang-kembang luka kan, because of baby keluar.
Asyik buat abortion dekat bilik.
Partner with multiple previous sexual partners. Okay, presence of cancer associated with HPV.
Tengok ni.
Yang ni, what are other cancer also associated with HPV? Cuba Google. Balik Google. Google now also can. Cancer associated with HPV. HPV virus. What are other cancers associated with HPV? Lagi? HPV kat bawah kan? So, kalau kat mulut boleh?
Boleh?
Boleh. Oral sex, you can have HPV infection of the oropharynx. So that can also lead to cancer of the oropharynx. So kalau dia ada another cancer with associated with HPV, pun dia ada risk of cervical cancer or ada high risk HPV infection. Yang tadi berapa? 16, 18, 31, 33. 51, 52, 55, 56. Alright. Certain HLA and virus subtype. Certain virus can also cause cervical cancer. Google up was a virus. And long exposure to oral contraceptive pills. Makan pil perancang lama sangat. Ada juga association with cervical cancer. Alright. Cigarette smoking more than 20 years. Smokers also risk factor. Genital infections such as infection with chlamydia can also cause cervical cancer. Uncircumcised male partner. So yang mana belum sunat tu sunat lah. So HPV akan duduk dekat dia punya prefuse tu kan. Dia perut dia. Okay. Lepas ni cuti tu sunat. Okay, tu sunat. Okay. Yang ni pun I boleh tanya in the exam, the histological types of cervical cancer. Remember the commonest is squamous cell carcinoma. Ingat? Squamous. Kenapa dekat cervix is the squamous cells? Kan dekat bila dia masuk kat canal tu jadi cervix baru dia jadi adenocarcinoma, right? Because it's columnar there. So squamous cell carcinoma more than 90%. Okay. Adenocarcinoma less than 10%. Okay. So adenocarcinoma dia develop from adenocarcinoma in situ. Tadi tu carcinoma, squamous cell carcinoma in situ. Dia akan jadi SCC. Kalau adeno in situ dia akan jadi adenocarcinoma. Alright. Okay, yang rare one adenosquamous. Dia ada dua-dua. Adeno dia ada, squamous features pun dia ada. Adeno means glands lah. Another rare one is neuroendocrine carcinoma. Is also rare. Okay, macam mana rupa squamous? I'll give this in OSPI as well. Normally give. Banyak kali keluar. Okay? We sometimes give this photo and ask you to describe this tumor. Or we give a photo of that yang tadi cervix yang ada necrosis kat tengah tadi tu. Describe the morphology of gross macroscopic features. And then kita bagi pula gambar ni. Describe the microscopic pula. Yang tadi dua mata, ni dua mata. Okay? And then kat bawah dia list 2 or 3 risk factors for cervical cancer or of this condition. Dah kan nak cakap jawapan kan? Of this condition. So kalau salah atas, salah dah bawah. Kan? Senang je nak hilang mangkam. Alright. So how do you describe this? So the whole thing there is a tumor. So this is squamous cell carcinoma. Ni rupa dia. Squamous looking. Squamous looking. So all these are infiltration by malignant squamous cells arranged in sheets. Sheets macam kertas, sheets of papers. The sheets of malignant cells infiltrating into the stroma, and then the cells exhibit squamous pattern. Squamous pattern tu macam mana? Dia ada large nucleus with abundant eosinophilic cytoplasm, and you see this. Apa dia bulat-bulat ni? Keratin pearls. Dah banyak dah makan kat situ. Cakap malignant cell satu arrange in sheets ada markah. Ada nuclear enlargement, nuclear polymorphism satu markah. Keratin pearls 3 markah. Apa lagi? Large abundant eosinophilic cytoplasm and yang ni intercellular bridges. There can also be mitosis Ni mitosis. Nampak tak kat keratin pulse ni macam hitam-hitam, tak cantik sangat lah. Itu be mitosis. And sometimes you can also see necrosis. Sekejap I nak tunjuk the intercellular bridges. Nampak tak? Ni higher power of the squamous carcinoma. These are the hyperchromatic and pleomorphic nucleus. Kenapa dia hyperchromatic? Kenapa dia gelap? Dia hitam. Hyperchromatic tu gelap lah. Sebab dia ada banyak DNA content. And nak tahu dia squamous, yang tadi dia ada keratin pulse. That is one feature of squamous. Other than the polygonal shaped cells, okay, with hyperchromatic nucleus, with abundant eosinophilic cytoplasm, 3 markah, with intercellular bridges. Mana dia? Nampak tak satu sel dengan satu sel ni dia ada senggat-senggat ni? Those are the intercellular bridges. One cell to another ada bridge. Okay, macam yang nak seberang pipi ni kan? That is intercellular bridges. And yang lain dia describe lah. Ada prominent nucleoli, ada mitosis. This is probably mitosis there. Okay, so all those are marks. Okay, so kena hafal. Okay, macam mana kita diagnose cervical cancer? Daripada dysplasia tadi, SIL tadi dah boleh diagnose lah. Okay, provided patients come for every 2 yearly pap smear or yearly pap smear, then we can detect. Kalau tak pernah umur hayat pun, dah umur 50 pun tak pernah buat pap smear, that's how you miss. You can miss cervical cancer. So what we can see in the pap smear, we do pap smear, and then if the smears are abnormal, and then you do biopsy. So this is what you see in pap smears in the slides. These are normal squamous cells. Nampak dia punya nucleus, pinpoint, small, abundant cytoplasm. Yang ni dah ada coilocyte. Maknanya dia ada nuclear enlargement with perinuclear halo, and the nucleus is enlarged, but the cytoplasm is still a lot. So this is CIN1 or low grade squamous intraepithelial lesion. So gambar B tu is low C. Okay, tengok gambar C. Gambar C mana dia? Okay, C, the nucleus is a lot larger than this, than CIN1. Tapi dia, okay, it's like the NC ratio dah more than half. Dia dah almost, the size of the nucleus is dah makin besar, more than half of the cytoplasm. This is CIN2. CIN2 dah high C. Okay, yang ni lagi besar. In relation to the cytoplasm tau. Bukan besar yang ni kecil. Okay? In relation to the cytoplasm dah tinggal sikit, the nucleus lagi besar. Dah more than half of the cytoplasm. That is CIN3 or high C. So yang bawah ni, C dengan D ni dua-dua high C. Yang B tu is low C with coilocyte. Yang bulat yang ada perinuclear halo tu is the coilocyte. Coilocytes are HPV infected cells. Okay, human papilloma virus high grade. Okay, yang ni, what about this one? Yang ni dah ada berudu-berudu ni. Dia ada keratinization. If you see orange cells like that, that is the individual cell keratinization. Yang berudu-berudu ni is tadpole cells. When you see tadpole cells with dirty background, banyak neutrophil, ada banyak necrosis kat background, this is squamous cell carcinoma. So it's so important to perform a pap smear, especially those in reproductive age group ataupun in sexually active age group. You kena buat at least 2 yearly pap smear to detect all these abnormalities and to detect squamous cell carcinoma early, cancer of the cervix early. Okay, faham? Ni pap smear. Okay, so cancer of the cervix, they can extend to the vagina, to the corpus of the uterus, to the parametrium of the uterus, the lower urinary tract, uterosacral ligaments, to the lymph nodes. Kalau dia pergi first station nodes, the paracervical, hypogastric obturator, external eyelid lymph nodes, that's what we call first station lymph nodes. Second station are the sacral lymph nodes, common eyelid lymph nodes, aortic, inguinal lymph nodes, second station. And then it can also, the cancer cells can also go to the lungs, the bones via the metastatic spread, via the blood. Yeah? And dia boleh juga pergi ovary, but it's very rare. Alright. So macam nak treat? Kalau masih CIN1, kita buat pap smear, nampak CIN1, they can do a wire loop excision. Dia buang ectocervix, dia macam kikis buang kat situ je. That's what we call wire loop excision. Buang, that's it, treated. The dysplastic changes has been taken out. Okay? Tapi kalau CIN3, kena buat cone. Cone means buang the whole surface tu. With margin kena clear. Yang tempat uterus tu kena tak ada dysplastic cells. Kalau ada, it will grow back, right? Okay, kalau the cancer, cervical cancer, you kena buang the whole uterus with the cervix. That's what we call hysterectomy. And also take out the lymph nodes, which is lymph node dissection. And this operation, you call it Wertheim hysterectomy. Nama orang lah. Then, if dah stage 4, dah pergi bladder, dah pergi rectum, spread all over around the area, then you cannot do anything, you can do surgery, you radiate, you give radiation therapy, so patient baring, you bagi radiation dekat the pelvic area tu untuk matikan the cancer cells. Okay, that is what we call radiation therapy or radiotherapy. Okay, that's the treatment lah, just know it lah. Okay. Okay, habis on the cervix. So yang penting, ni penting cancer cervix. Selalu keluar exam. Kena tahu in and out. MCQ ke, SAQ ke, OSPI ke, memang suka keluar di cervix. Okay, go to the uterus. Yang penting in the uterus is endometrial hyperplasia, endometrial cancer. Sebab dia related. Hyperplasia boleh jadi progress to cancer. Okay, yang ni boleh baca lah abnormalities of the uterus ni. Ada yang tak ada uterus pun ada, rare, absent endometrium ada, uterus kecil, hypoplasia, ada yang tak boleh fusion of the Mullerian ducts, ada yang ada septum kat tengah, okay? And then what's the danger of having all this? They can cause abortion, the embryo cannot speak because of these abnormalities. You can have a current abortion. Bila the pregnant boleh juga lekat tapi ada malpresentation, baby tu duduk tak betul, and malpresentation at labor. Masa nak bersalin tu baby sengit susah nak keluar. Dalam kena caesar, because of the abnormal position of the uterus ataupun dia ada septum kat tengah ni. And ada juga yang ada didelphys. Didelphys ni dia ada uterus dua. Ada sebelah tu, ada septum, ada sebelah lagi. Ada dua, two uterus. Call it uterine didelphys. Okay, endometrium. Sama juga, I have to go fast because endometrium, endometritis is infection of the endometrium. Pun tak common. Why? Because kita ada acid barrier from the vagina and also the cervical mucus. And also every month kita shed kan. The shedding of the endometrium. So dia buang-buang dia tak susah dapat infection. Tapi still boleh happen. Can cause acute endometritis and chronic endometritis. Ini baca sendiri tak sempat ni. PID is chronic endometriosis. Endometriosis ada dalam apa juga. Endometriosis is the endometrial glands tu duduk dekat luar daripada uterus. Or dia boleh duduk dalam uterus tapi dia tak duduk kat endometrium, dia duduk dalam myometrium. That is called adenomyosis. Dia potong dia nampak ping-pong blood dalam the endometrium. It shouldn't be. So that is adenomyosis. Dia duduk dekat myometrium, dia boleh duduk kat ovary. Kalau duduk kat ovary, you call it endometriosis. Kalau duduk kat myometrium, you call it adenomyosis. Dia boleh duduk kat cervix, dia boleh duduk dekat broad ligament, dia boleh duduk kat fallopian tube. We cut open, you see, there's endometrial tissue. So bila period, dia pun period. Ada my friend dulu, dia period kan? Pusat dia period. Pusat dia umbilicus, has bleeding kat umbilicus. Bila dia period, umbilicus dia period. So now orang tahu, dia ada endometriosis at the umbilicus. There's endometrial tissue there. When you have menses, dia pun menses juga. Okay. That's how it looks like. This is endometriosis dekat cervix. It can cause bleeding as well. These are the pathogenesis lah. Ada yang kata ada prograde dissemination of uterine fragments through menstruation, ada yang kata there's endometrium arising from the sygomic epithelium, ada yang kata endometrial tissue tu masuk dalam the blood vessels and also the lymphatic. How people hypothesize how ni dia adenomyosis. You see endometrial tissue inside the myometrium of the uterus. Okay, microscopically, that is endometrial glands in the myometrium. This is how it looks like. You see trabeculation, you see pinpoint blood clot or pinpoint hemorrhage in the myometrium. Okay, AUB, abnormal uterine bleed. Dulu kita panggil DUB, dysfunctional uterine bleed. Now kita panggil AUB. So AUB is very common in women. Dia bleeding, doktor tak tahu kenapa. Semua check, semua normal. Tak ada fibroid, tak ada cancer, tak ada polyp. Then you call it AUB, abnormal uterine bleeding in the absence of organic lesions. Organic lesion ni you tahulah apa punca dia. Ni tak ada organic lesions yang detected. This is the cause is because of an ovulatory cycle of the menstruation tu. Dia tak ovulate. Dia tak ovulate, it causes this abnormal bleeding. And what causes this anovulatory cycle? Endocrine disease such as thyroid disease, adrenal, pituitary, or lesions in the ovary, PCOS. What is PCOS? Polycystic ovarian syndrome or ovarian tumors, all these kinds of abnormal bleeding. Obesity or malnutrition, unknown, ada. And how in the bila bleed though, bila sample the endometrium, you see proliferative phase endometrium actually. Okay, okay. Now we go to the tumors of the uterus. Okay, benign tumors first. Leiomyoma or fibroid. Ni fibroid. The myometrium there, kat fundus. The multiple there can be in the submucosal in the endometrium, dia bulat-bulat cantik, it's cream in color, and how they can be asymptomatic but they can also present with bleeding, especially yang duduk dekat sini, dekat endometrial cavity ni. Yang duduk kat atas ni dia diam je, yang kat sini can cause menorrhagia or heavy menses. Okay? Or infertility, tak boleh nak conceive. Why? Embryo tak boleh nak lekat, banyak sangat benda-benda kat sini. Okay, cannot stick. Alright, so this is the microscopy. It's composed of smooth muscle cells, interlacing bundles of smooth muscle fibers. That is fibroid, but they are benign. And the cells, you tengok sel tu cantik, dia tak ada nuclear polymorphism, tak ada hyperchromatism, tak ada mitotic figures, so it's benign. Okay, it's a benign tumor of the smooth muscle cells. That is fibroid. Important one. Endometrial hyperplasia. So there is, when you say hyperplasia, maknanya the endometrial glands tu proliferate. Dia bercambah, membiak lah. Dia hyperplastic. And this results in to increase in gland to stroma ratio. There's a lot of glands in the stroma. And kenapa dia proliferate tu? Because of exogenous estrogen or endogenous estrogen. Maknanya ada extra estrogen that's stimulating your endometrium to proliferate and becomes hyperplastic. Okay, orang mana? Siapa yang dapat yang makan estrogen, yang inject estrogen, yang ada extra or yang obese. Obese, you have also a lot of estrogen because the androgen will be converted to estrogen. Daripada fat cells. Your fat cells. Okay, we'll go into that later. So there are two types of endometrial hyperplasia. Hyperplasia without atypia, mana nucleus tak ada atypia, tak ada atypical nucleus, tak ada nuclear enlargement, tak ada nuclear polymorphism, tak ada hyperchromasia, tapi glands je banyak. That's what we call hyperplasia without atypia. And the second type, ada atypia, ada nuclear atypia. This one we call it atypical hyperplasia. Yang ni yang akan jadi cancer. Sebab daripada awal nukleus dah hyperchromatic, dah enlarged, dah ada nuclear polymorphism, mitotic figures, dah ada prominent nucleoli. This is what we call EIN, AH or EIN, endometrioid intraepithelial neoplasia. So AH or EIN ni is a pre-malignant or a precursor for endometrial cancer. Okay. So bila dia hyperplasia, selalunya dia ada abnormal uterine bleeding or PV bleeding. Selalunya lepas menopause. Tapi sebelum CPCP belum tu ada orang dah ada. Especially bila ada risk factors, dia gemuk, dia obese, dia ada diabetes, dia ada hypertension, dia ada banyak estrogen, dia boleh ada endometrial hyperplasia. Okay, then the endometrium is thickened. When you do ultrasound, it's thickened. So you have to scrape you do endometrial biopsy. Tengok under microscope, betul ada hyperplasia. Then you have to treat lah. You give progesterone. Kan dia banyak estrogen kan? Bagi progesterone pula. To counter the effect of estrogen. We call it progestin. Progesterone tu progestin therapy. Kalau nak conserve the uterus, you give progestin therapy. Tapi kalau you dah menopause, tak nak pakai dah uterus, buang je lah. Takut jadi cancer kan? Daripada bagi progestin sahaja. Okay, this slide is important. These are the risk factors or the causes of endometrial hyperplasia. There's excessive or prolonged estrogenic stimulation or absence of progestational activity. Banyak sangat estrogen atau tak ada progestrogen. Kalau sianya, kejut yang bertudung pink tu, kawan sebelah ni. Bangun. Okay. So, endometrial hyperplasia is caused by all this. Obesity. Kenapa? Dalam adipose tissue ada enzyme converting circulating androgens to estrogen, which is found in adipose tissue. And adipose tissue, these androgens will be converted to estrogen, and there will be hyperestrogenism. And estrogen akan act on the endometrium and becomes hyperplastic. Okay, that's obesity. Or dia boleh ada diabetes, dia ada hypertension pun boleh juga. PCOS. PCOS also increase circulating androgens and it is converted to estrogen. Okay, nombor 3 tadi, dia tak ovulate. Okay, there's chronic anovulation or infertility. So there's high estrogen. Stein-Leventhal syndrome also produce estrogen. Okay, a syndrome with a lot of estrogen. And also ovarian tumors can secrete estrogen. Venerosa cell tumor, theca cell tumors. Or there's cortical stromal hyperplasia in the ovary. Or that leads to hyperandrogenism and then converted to estrogen, hyperestrogenism. Or dia ada breast cancer. Dia diberi tamoxifen. Okay? Tamoxifen is an estrogen replacement therapy. So tamoxifen ni ada estrogen. Okay? Dibagi tamoxifen untuk breast cancer, tapi dia dapat another cancer. Okay, hyperplasia and then cancer. Or dia bagi hormonal therapy untuk orang menopause. Orang menopause kan tak ada estrogen, dah kurang kan, low estrogen. So clinician pun bagilah, kat ini dia bagi estrogen, makanlah estrogen. Tengok-tengok dapat endometrial hyperplasia and then cancer. So those are the what we call estrogen replacement therapy. Okay, so those are the causes of endometrial hyperplasia. Okay. So macam mana rupa dia? In hyperplasia, there can be flashy endometrium, dia macam jadi polyp macam ni, tapi dia bukan polyp, cuma dia flashy. Okay. Kalau hyperplasia without atypia, dia endometrium, dia ada microscopy. There's a lot of endometrial glands with glandular complexity, no nuclear atypia.
Focus.
Then the atypical hyperplasia, there's hyperplasia and there's atypia, nuclear atypia. So kat sini the cells are, the glands are more complex or back to back, very packed, tapi with nuclear atypia. Okay, I'll show you. Okay, this is hyperplasia without atypia. Banyak glands, ada yang branching, tapi stroma dia ada banyak lagi in between. And dia tak ada nuclear atypia. The nucleus are not enlarged, hyperchromatic, prominent nucleoli tak ada. Okay, next photo. This is complex. This is atypical hyperplasia. Dah rapat-rapat dah, dia ada glands and dia ada nuclear atypia. Nampak nuclear atypia tu? Besar, nucleus besar, prominent nucleoli, stratified nuclei. This is atypical hyperplasia. Yang ni yang akan jadi cancer. Okay, 2 types. Alright. Now we go to endometrial cancer. 7% of cancers in women, okay, and increasing in incidence. Selalunya in developed countries. It's the most common gynae malignancy in developed countries. Age 55 to 65, postmenopausal lah. 80% arise in postmenopausal women. These are the risk factors. Atypical hyperplasia, obesity, diabetes, hypertension, infertility, AUV, prolonged tamoxifen use or prolonged estrogen use. Lebih kurang macam endometrial hyperplasia tu sebab dia punya causes sama. Stein-Leventhal syndrome, Turner syndrome sama. Then they present with abnormal vaginal bleed. Tengok ni, dah jadi cancer dah. Very fungating growth in the endometrium, that invade the myometrium. When you cut, it's already fungating out. Polypoidal tumor. Ni penting. Ni boleh tanya dalam exam. MEQ boleh. Okay, the 2 microscopic type. One is endometrioid carcinoma. The second type is non-endometrioid carcinoma. Okay, kalau I tanya ada 2 jenis, you boleh lah cakap endometrioid dengan non-endometrioid. Tapi non-endometrioid, maybe you can describe the serous type yang most common. Okay, ada 2 type. Yang 85% are endometrioid. Apa beza? Kalau classification of the endometrial carcinoma in WHO book, jadi endometrioid, and then yang lain ni semua, mucinous ni ke atas. Mucinous are the type 1. Yang the non-endometrioid are serous, clear cell, transitional, small cell, squamous, undifferentiated, carcinoma, sarcoma, mixed type. Yang bawah tu ada non-endometrioid. Okay, type 1. Type 1 endometrioid. Endometrioid or type 1 are estrogen dependent tumors. Mana memang estrogen yang menghasilkan dia punya cancer. Okay. Type 2 non-endometrioid, they are not estrogen dependent. Tapi yang mana lagi jahat? Yang type 2 lagi jahat. They are not favorable, they are aggressive tumors, not estrogen dependent, they are poorly differentiated. Example, serous carcinoma. Yang ni nama dia memang endometrioid carcinoma. Okay, so if I ask you, give 2 examples. One is endometrioid carcinoma, one is serous carcinoma. I might ask you what's the difference between 2 microscopically. Okay, I'll show a photo of this. Endometrioid, dia compact glands, back to back, irregular. Okay, dia macam it's all here lah. Complex papillary, micropapillary structures. They resemble proliferative endometrium. Okay, there is nuclear enlargement, large nucleoli, loss of polarity, ada stratified nuclei. Okay, there is sharp luminal borders. What do I mean by sharp luminal borders? Ni lumen kan of the cancer gland. Dia straight lumen dia tu. Tapi kalau in serous, dia macam point tu ada wobbly punya surface. Okay, they can be in sheets pattern. Okay. Okay, ini serous. Serous dia slit like, dia ada macam nak tercabut ni. Kan dia macam tu kan. Cells dia tak straight macam tadi. Okay. They are gland-like spaces with luminal borders are not sharp. As in the endometrioid tadi. Ini serous. And they can also be solid growth pattern, tapi dia ada can have samoma bodies. Ni samoma bodies. Yang classification yang purple ni, they can have samoma bodies. So kalau I tanya type 1, you describe yang endometrioid tadi. Type 2, you describe serous. Okay, with the samoma bodies, and then the non-straight borders. Okay, malignant cells, malignant glands, back-to-back pattern sama. Tapi yang ni dia ada P53 expression. Serous dia ada P53 gene expression. Okay, one can read yourself. There's a photo. Mesenchymal tumors, malignant, ada bagi tahu Terus aku takut ambil masa dia. Okay, this one is a mesenchymal tumor, meaning from the soft tissue. Or the name is carcinosarcoma. It's not common, And here you see glands, you see sarcoma component, and you can see muscle, cartilage, and also differentiation, and present in postmenopausal women, and highly malignant, very malignant. Okay, dia macam ada cartilage, these are the gland component. So this is carcinosarcoma. The epithelium ni is the carcino component. The soft tissue component, the cartilage, is the sarcoma component. So it's called carcinosarcoma. Another name is malignant mixed Mullerian tumor, very aggressive tumor. Okay, of the uterus, of the endometrium lah. Okay, yang tadi kita kata leiomyoma benign kan? So the malignant counterpart is leiomyosarcoma, but thank God it's not common. Tapi it happens. Ada my friends orang tu died of it. It's fleshy, bulky mass in the uterine wall. Okay, mitosis banyak ada. Okay, that's the malignant leiomyosarcoma. You can see very atypical cells, hyperchromatic nuclei, fine nuclei, mitosis. This mitosis ada tumor, multinucleated giant cells. Okay. Alright, GTD. GTD is a gestational trophoblastic disease. There's abnormal proliferation and maturation of trophoblasts. When ladies are pregnant, they have this trophoblast punya proliferation. Kat sini dia ada abnormal proliferation, which can lead to molar pregnancy. Molar pregnancy dia mengandung anggur. Dalam rahim dia ada anggur, macam vesicles. Can be complete mole, partial mole, can be cancer. Ada 3 jenis. Okay, complete. Ni anggur dia, grapes, bunch of grapes. Macam dia tak period, tapi kenapa dia tak scan tak nampak baby, tapi nampak anggur. Okay, that's the chronic villi. So what happened? It can be composed of masses of friable, grape-like cystic structures filling the endometrial cavity. Tapi there is because of fertilization of empty ovum. So sebab ovum dia empty, dia tak ada fetus. There's no fetal parts. And then macam mana dia punya ni genetic? The 23X duplicate to 46XX. Kat sini Then telur tak ada DNA telur, tapi ada 2 sperm XX, and then dia akan jadi 46XX. Okay. Atau 1 sperm campur dengan non-maternal DNA pun akan jadi 46XY. Okay, yang tu complete mole 2XX atau 23X duplicate jadi 46XX. And these patients, they bleed. They have PV bleed selalu dekat 11 week of post POA, period of amenorrhea. 11 minggu tak period. Ingatkan mengandung lah, tapi mengandung anggur. Okay? And the beta HCG is highly elevated in the blood. And 2% can develop choriocarcinoma. Okay, kalau partial mole, dia ada separuh normal chronic villi, separuh lagi abnormal chronic villi. Why here? There's 23X or 23XY akan campur dengan telur 23X, dia jadi triploid. Dia jadi 23X, 23Y, 23X. Okay, or dia akan jadi 69XXY or 69XXY. Jadi orang kena baca kalau tak faham. Okay, partial. Sebab partial dia ada fetus, tapi dia semua anggur. Tapi there is fetus formation because the egg is there. Yang tadi there's no eggs, no maternal. Yang ni dia ada. Okay, so the karyotype is triploid, 69XXY or tetraploid 92XXXY. Yang dibaca tak sempat. Ni partial mole ada yang normal villus, ada yang abnormal villus. There's edematous chronic villi. There's proliferation of the trophoblast kat luar. Okay, and the rarer one is cancer. In pregnancy pun boleh ada cancer of the trophoblast. It's choriocarcinoma. So the tumor of the trophoblast. 50% arise in the multiple mole, 25% in previous abortion, 22% in normal pregnancy. Boleh juga normal pregnancy pun boleh jadi cancer 22%. Rapidly invasive, metastasizing, invade myometrium, more than 90% metastasize to the lungs. It has high ACG, beta HCG hormones in the blood. The muntah-muntah because of the high ACG. And this is how it looks like. Bloody uterus. Irregular bloody hormone. This is cancer cells, all this choriocarcinoma cell. Okay, Amanda. Kan, lepas ni ada ovary kan? Okay, any question you all need us? Boleh tanya later in the practical box. Okay, that's all.
Kena di kat sini kan? Kelas.
Yes.
Nanti sambung kat sini kan?
Tak boleh draw sambil tolak.
Sure.
Aku nak try.
Boleh.
Thank you, doktor.
Thank you, doktor.
Thank you, doktor.
Boleh lah ni. Control Z.
Mau. Ni control ke?
Command. Sebab ni command.
Tak.
Macam ni. Ni dah buat.
Adilah.
Kalau tag one,
Just
Kalau
dia
Andu
tak
boleh lah.
effect Andu tahu.
serius sebenarnya.
Andu tahu. Just ada addition lagi satu dia tak.
See. It's not control lah.
Command in iPad is the same as control. Ah, Dr. Mai Zatun. Anggur.
Oh, this looks like barbecue chicken.
Do you remember this in penis?
No, where is it?
Korean carcinoma?
Did we have that?
Kind of the same name but not
Oh, I
same.
can't remember.
No, it's still the same. Fried chicken. Tahap. You can taste it later.
Oreo carcinoma.
Oh my god, that's scary. Beautiful pen.
You like everything, huh?
Huh?
You like everything. You just buy this iPad lah. Buy this iPad, buy this keyboard, buy this cover.
How long you take to charge?
5 minutes.
For how long?
70%.
5 hours.
Huh?
5 hours.
5 minutes.
I know, but for how long the duration it's
Oh.
working?
I don't know. Quite long, huh? 1 day.
Oh my god. Gila.
Fried chicken, drumstick, and alright. Let's go.
Assalamualaikum, good afternoon.
Waalaikumsalam, doktor.
So for today's lecture, it will be on the pathology of the ovary and fallopian tubes. So you just had a lecture on endometrium and cervix, right? So endometrium and cervix, the pathology are much more common than those in the ovary and fallopian tubes. Okay, first, basically, what is expected of you from this lecture is